my presentation is about some research I pulled up about Ehlers-Danlos syndrome. And so a little bit about this case and myself. So I'm new to all of this. Just, I changed, decided I'm going to change the way I practice after I met Rebecca and saw her at CSM in February in San Diego. And I was like, holy cow, like we are missing a huge population here with maternal health. And so it just so happened that the week after I went to go do this, and I pitched this idea to my boss that, hey, I want to do this at our hospital. My boss was like, great, like, let's do it. Let's figure out some stuff. And then like that week, we actually got a case study at our hospital, which I'm going to present here in a second. But so my hospital, I work in Akron, Ohio, which is just kind of south of Cleveland here. So we're pretty close with Cleveland Clinic. But our hospital is SUMA Health System. So we're a level 1 trauma center, and I'm an acute care physical therapist at our trauma center. And we're also a level 4 perinatal center. For those who are not familiar with that, level 1 is like for trauma is the highest level care, but then it's opposite for perinatal. Level 4 is actually good. That's the highest level. So it kind of flips. So we're a level 1 trauma, but then a level 4 perinatal for high risk pregnancies. And so I've been working there for a couple years, and a week after I presented to my boss this idea that I wanted to get an acute care program going, the labor delivery and the maternal units at our hospital, every now and then we get these blue moon random orders for patients, and it just so happens that week my coworker was like, hey, we have an order for post-op C-section on mother baby, like right now. And I was like, what? I was like, how did this happen? Like, how did they find out that I'm trying to do this? And it actually wasn't even about the C-section. They called therapy because she has Ehlers-Danlos syndrome. So this is patient R for short. And so she is, it's a 25-year-old Caucasian woman. This is her first pregnancy, prior history of E.D.S. with hip and shoulder dislocations in high school. And then we have a history of IBS. We have a history of anxiety and depression, and then also obesity. At 36 weeks, she had a BMI of 60. So that is including her pregnancy weight. But again, if we reduce that pregnancy weight, it's still not going to come down to, I don't have her pre-pregnancy BMI, but I imagine she didn't go from a regular BMI to 60. She did have preeclampsia with her pregnancy. And was being treated with antihypertensives. When she was in labor, she was failure to progress. So she was almost at 36 weeks, and she had a CAT2 fetal heart rate. And then they gave her the epidural, and so she went from being hypertensive to hypotensive. And I'm going to talk about that in a minute of what could have happened with that. She ended up having a C-section, and her baby did end up having to go to the NICU for a couple of days after delivery. And PT was ordered post-op day 2 for hip pain with E.D.S. After her surgery. So some background information on her for this case study some more. She lives with a boyfriend in a single apartment, so not really some stairs that she has to worry about. But her boyfriend, the father of the baby, works 12 hours a day, 5 days a week, and will not be taking paternity leave because of financial situations. Her mother is involved but has MS and has limited lifting abilities. And limited ability to physically assist with the baby and with the mother. Her job status. So she told me she was working. I did not get more information about what her job was, but she was planning on going back to work soon because of finances that she was expressing. And then she did express, so the good news was she talked about her physical therapy she had in high school for her hip dislocation. And overall, she had a very positive experience with that in order to get back in the marching band. And so just real quick, Ehlers-Danlos, it's a connective tissue disorder. I always thought of the hypermobile, and I forgot that there's so many different forms of Ehlers-Danlos. The most common is the hypermobile, where people are overly flexible, like the images on the slide over there, where they can flip their thumb back and hyperextend their knees and their elbows. But that's about 1 in 3 to 5,000. I got varying numbers on that when I looked online. But you can have other forms. There's the skin hyperextensibility, which there's that photo, like the skin just stretches. They can have GI issues. where it's not very mobile, and they get a lot of constipation and other issues. And then a lot of tissue fragility. So basically, just things rupture, tear, break very easily. It's very thin. And so that happens a lot with like the blood vessels. You get a lot of issues with that, the heart. And then a lot of the abdominal organs can have issues, which I'll talk about some more. And then the eyes too. I didn't realize that can be involved also. And it's diagnosed by a rheumatologist, usually. And then, so I won't go into this too much. So there is a lot of research to support pelvic physical therapy for Ehlers-Danlos syndromes because of the hypermobility and the tissue extensibility and the fragility. There's so much research that supports physical therapy being involved in outpatient, but there's really not a lot of information about physical therapy being involved in an acute care setting, especially for our postpartum patients. So things to consider with Ehlers-Danlos that I did find online. So the first thing with Ehlers-Danlos is they are at higher risk for or higher rates of having a C-section versus a vaginal delivery compared to general population. And there's many reasons for that. One reason that they may be more likely to have a C-section is purely because they want to. If they have a prior history of dislocating and they know that it's not going to go well for them to push and to get into those stirrups, there are people who elect for a vaginal delivery. I don't have numbers on that, but there is just a lot of cases that talked about that. And I've heard from pelvic physical therapy friends that have talked about they've known patients who've done that. So it may be a choice by the mother, and they're also at higher risk for perineal lacerations with vaginal deliveries too, because of that tissue extensibility and fragility. And then also they have higher complications, especially with like cardiac issues and tissue membranes rupturing like early, like when their water breaks early, things like that, that would require them to have an emergency section. So they may not be safe to be able to do a vaginal delivery, and they may have to do a C-section. So they're at higher risk for having to have a C-section and higher rates, but also they have higher concerns and things that could happen to them if they do have a C-section. With the capillaries, they're at higher risk for hemorrhaging and having hematomas with the tissues rupturing more, like I mentioned earlier. And especially, we already know that C-section patients can be at higher risk for hemorrhaging, especially with the vasodilation that's going on, the hormones, and also the proximity of everything when they go to cut you open for that surgery. It puts them at an extra risk for hemorrhaging with the E.D.S. And then they have a decreased response to anesthetics and analgesics, which I learned about. I didn't know that. So a lot of times the normal doses for like that age and body weight don't affect them. And so they have to have higher doses or their cardiac system doesn't react as well. And so that's kind of what happened with patient R, it sounds like, where she was hypertensive and then they gave her the epidural and then she was hypotensive. And then another thing to consider too is the tissue fragility, the skin stretching. They're at higher risk for wound healing too at the incision. So the concerns that we would have with this patient that we can talk about, the hip pain with the dislocations, that's a musculoskeletal thing that physical therapy can treat. And we don't have to wait for outpatient. That's something that we can treat in acute care. I see people in acute care who with falls and things like that, even if they don't break something, they have hip pain. And I treat that in the hospital. I treat that in acute care. Pelvic pain, SI joint dysfunction, we already know that with pregnancy, you're at higher risk for all of those things. But E.D.S, you're at higher risk because of you're already hypermobile, and then your pregnancy, you become more mobile to allow the pelvis to expand. So you're like, it's double edged, it's double hit there. And then the abdominal incision. So I treat a lot of abdominal surgeries in our hospital. And so they have that incision in there. And we already know that C-section patients also have that abdominal incision that's going to affect their low back and things like that. But E.D.S patients have high rates of low back pain already without pregnancy. And so for my patient, for pelvic physical therapy, she'd never heard of it before. She had physical therapy, but not pelvic physical therapy. And so I was able to at least go in and educate her and tell her like, hey, I know you had this positive experience before, but there's people who are trained specifically for your pelvic floor and in conjunction with your hips and your back to reduce pain, especially with pregnancy. You already have, the E.D.S, you have I.B.S, which I'm going to get into a little bit with that too. But just to be able to be in that setting to educate and advocate, like these are things that are services for you, and we can treat you early so it's not causing issues down the road. Other complications too. So E.D.S patients are at high risk for POTS. I did not realize that. That was something I actually learned. There's high rates of that. I found varying numbers on that. Our patient did have the preeclampsia already, which is something I talked about. Hemorrhage and hematoma is such a huge thing. Pneumonia and DVTs after any C-section for sure. At risk for all those things. Constipation, our patient had I.B.S, so she already had a chronic history of constipation, and I.B.S can be very common with Ehlers Danlos. So again, it's adding on to these things that already can be complications with C-sections, but now it's more prevalent and worse. Pelvic organ prolapse, and then also just doing functional mobility that promotes wound healing. These are all things that we would treat in a hospital in acute care for abdominal surgeries, or patients in ICU, trauma patients with hemorrhaging and things like that. So even though there's not research to support acute care physical therapy for Ehlers-Danlos, we already have the research that supports outpatient pelvic therapy for Ehlers-Danlos, and we have the research to support physical therapy and acute care for these types of complications here, hemorrhaging and all this other stuff that we already know. Let's combine it together and, get to the point where I really I'm working on trying to fight for acute care physical therapy in general for post-op C-sections, but I just learned so much that Ehlers-Danlos, it just has higher risk for like all those things. So I kind of put on here everything that we talked about already, like the social determinants of health. How can we treat that? Getting her some support at home with home health, and then putting that referral for outpatient and maybe do some return to work training. Preeclampsia, I did not get to monitor vitals with this patient because she was actually in the NICU visiting her baby. She allowed me to come see her when she was in the NICU. So it was a very weird setup. So I didn't get to do vitals, and she had already been up and moving. So I did not get to do vitals, and that was a learning experience. I really want to push for that more. Incision healing, any abdominal surgery, we're getting them binders. We're getting them proper wound care for the incision. We're getting them cues of how to log roll in and out of bed. We're already doing that stuff with abdominal surgery patients. Why can't we apply it to these patients? Bowel concerns, again, she has I.B.S. What can we be doing about that? Breathing, positioning, helping get laxatives, helping educate about things that can promote bowel activity. And then kind of tying in with, this was kind of perfect. I put this at the end here about the mental health. And Kristi, you talked so much about this, but what can we be doing in this setting to help promote after any delivery in general? What can we be doing? We can be screening for postpartum depression and blues and all those other conditions you talked about. We can be screening for any other like conditions that might be concerning. And we can teach them how to be independent, how to be self-efficacious, and how to take care of themselves and give them that time and space to be like, this is for you. Like, I'm here for you. Like, I know there's a lot going on with the baby, but I'm here for you. And, if there's any concerns you might have, let's talk about them. Let's do that. And let's figure out ways to tackle that. And I think that can be super therapeutic for people to be able to learn how to take care of themselves again. And I'd really like to hear from other people, kind of segue into the group talk of what everyone else's experiences are with E.D.S, because it is, I think there's a lot more education that's coming out about E.D.S and physical therapy, but especially pelvic physical therapy. And then I have some resources here if anybody is interested too.